medicine of oculoplasty, and we can see some of the big names of oculoplasty already here, and we get a few more. So I guess we should start, and we have none other than Dr. Usha Kim to give the first talk. She is the head of oculoplasty orbit of oncology at Arvind Madurai, and of course, few thousands here in AIOS would have trained under her, either directly or indirectly, or just imbibe so much from her just listening to her. So, an absolute pleasure to have you here, ma'am. She will be talking about how to get the best out of my fellow, the key words.
That's a very generous introduction. Thank you so much. So the topic is how to get the best out of my fellow. I wasn't sure when I got this topic, but then I decided if we have to get the best out of the fellow, we have to give the best to them, produce the best. So I know, I'm sure, I mean, Jyoti has done a very good job and made my job very simple. We should understand that it's a win-win situation for both the parties, the trainer as well as the trainee. So for the fellow, the oculoplasty fellow, so the oculoplasty is oculoplasty orbit, and now it's oncology as well. So we have a big basket full of things. So we have a lot to train. We'll have to look at their academic part, as she rightly presented earlier in the session, and look at their advancement. Whatever they know has to be enhanced, and also create a networking opportunity, because it's only through networking that we enhance our work and also learn from each other. But for the organization, again, because that's what the topic meant, how to get the best out of the fellow. Way to recruit talent. Okay, you need to have more oculoplastic surgeons. You have to. This is an opportunity for us to look at it. And also, the organization has a specific purpose. You know, like Arvind has, where I belong to, has a very specific purpose. In order to enhance or augment our specific purpose or the cause that we're working for, we need to have more talent. And of course, I think the younger generation is the best to have innovations. And that's the place where we can get the innovations to come into the field. Now, what do we do actually? What we need to do is, we need to look at the people before they get into the fellowship mainstream. So there are certain pre-entry mandates for the fellows who are going to be absorbed into the system. What we do, I'm just sharing what we do, so it could be augmented with your views as well. We make them interact with the existing fellows, so they know exactly what they're getting into. They spell out exactly what to expect. Either the head of the department or the senior fellows or the others, senior colleagues will spell out what to expect, both in the academic as well as in their professional front, and also share the strengths of the program. Each organization would have a strength, each hospital would have a strength. You can share the strength of the organization and then also allow them to network with the alumni. During the fellowship, as Dr. Jyoti was mentioning, it's very, very important for them to observe with the seniors, because that's where you learn how to communicate, how to counsel, and how to treat a patient. Because what's most important and what's the bottom line is the attitude, the way we handle our patients. Otherwise, we will also be joining the strike like we did today, because attitude is ultimately the one that's going to hold us high. And let them participate. So in oculoplasty and orbit, we have various other disciplines also, which Dr. Marian will be talking about in the next talk. But then we have certain things that we need to encourage them to be part of. Like, for example, imaging. You have a tumor, you need to know exactly where the tumor is. What are the anatomical damages that the tumor has done? What are the structures it's going to be affecting as you're going to surgically remove the tumor? So it's best that the fellow goes and sits with the radiologist and discusses with the radiologist, and then correlate with the clinical findings also. So it's a point where they can talk to the radiologist, tell them that there is an intermediate loss of vision, and this lesion doesn't seem like, I'm assuming clinically that it's going to be a hemangioma, but then it's causing an intermediate loss of vision. Is it pressing on the optic nerve? So if you have a discussion with the radiologist, allow these fellows to go and interact with them. That will be an opportunity for them to learn. And of course, histopathology is the mainstay for us, and all our diagnosis depends upon histopathology. So allow them to interact with the pathologist as well. And as was mentioned by Dr. Jyoti earlier, as you're doing certain cases, you can allow them to read, analyze, and also write the manuscript. Like, for example, you've seen three cases of something very unique. You allow them to sit down, analyze all those three cases, and write up immediately so that they get into the habit of writing. And throw questions at them, clinical questions at them. Why is this that this particular condition you've seen in the past few months has been occurring very often? Why is it that this subset is having this particular problem? So throw questions at them and then allow them to have a research project and let them attend conferences like the ones we are attending now and allow them to operate and manage the OP. So initially you start off teaching, like we have multiple stages. You start off teaching them, then you allow them to operate and you allow them to manage the OP. So in the previous session mentioned that you need to show them instruments. It's not, we've had frantic calls from our fellows. How do we sterilize this particular instrument? Where do we acquire the sterile strips that you have? So you need to let them operate and also manage the OP so that they gain the confidence when they're let into the open. And this is very, very important. It's always good to expose them to different surgeons because that gives them a bigger kitty to work on. They have finer tips from each of the surgeons and they could use that later on in their lives. And then most important, I think it's very, very important, however intense you are and however big a techie you are, as I see one walking in, however big you are, you need to have some notes written down every day as you see cases, as you discuss. You need to handwrite them so that you can refer to them later on in your life. And a logbook is very, very important because in orbit and oculoplasty, you have a variety of cases. You have different sections in oculoplasty, you have different portions in orbit, you have different sections in oncology. So each of these areas would require an intense logbook maintenance, and these logbooks have to be monitored by either the attendees or the HODs every once in a while. So I think what's really depressing is sometimes the training is not prioritized for the fellows. I'm not ashamed to claim myself as part of one who doesn't seem to prioritize training as one of the most important things. When I say prioritize training is give them the adequate time, sit with them and train them through and through, like handhold them literally on a day-to-day basis. We must prioritize training and involve them in decision making. So as you see, you don't have to see numbers. Even as you're seeing a few cases, allow them to participate in the decision making and encourage them to question. A lot of times it's just that you tell them that this is a case of cavernous angioma. It requires an orbitotomy and the lesion has to be excised. So that's not the way to train. Allow them to participate, allow them to make the decisions, and then probably you can fine tune as you go on. And I think it's very, very important for them to also interact with other seniors in the department or in the other departments. And it's very important to have a peer group where they're allowed to discuss and they come forward with different ideas. And very, very important is whenever you get an opportunity, try to engage the guest speakers. They might visit your city, they might visit your area. Please drag them in and allow them to interact with their own fellows. That's the best way to learn from different people in the subspecialty. And it is very important for us to, as was, I think Jyoti had summed it all for all the fellowship programs. It's important for us to expose them to research opportunities and also the teaching opportunities. They might be very good in teaching as well. So what you sow is what you reap. So if you have trained them well, the volume that you are having in organizations or institutions can be handled very well without much of a problem. And then you can utilize them very well for the data collection for research. You can motivate them to teach the PGs, fellows, and the other allied ophthalmic personnel. And by this, when they teach, they also learn a lot more. And what I see is the fellows have created new teaching methodologies, and these are the ones who have innovated ways in which they can teach their younger ones and they could be very good resources for their junior fellows as well. And it's very important to allow them to engage in innovations, which could be either in the management of diseases, or it could be in the teaching or research aspects. So good teachers know how to bring the best out of the students. I think that's what I've been asked to do. So thank you very much for the opportunity, and open for questions and
Thank you very much. That was wonderfully put in perspective. Again, a lot of these discussions are meant for the entire subspecialties that we're dealing with, while they've been classified to subspecialty wise, so that you can look into a little fine tuning of these general rules for that subspecialty. But essentially, they hold true for all, especially pediatric ophthalmology students, because ophthalmology we've been talking about that because of the absence of too much technology, it is human resources that we are building. So as you said, you need to take out a lot of time, because that's the only way you can have the next generation do what you always want or you were trying to do. So thank you. Any comments? Chair, any comments on this? And then we move on. Mike, will you take the mic, please? Excuse me. Mike.
What do you will take the mic?
In the meantime, I'll also ask my co-moderator, Dr. Satyajit Sinha, to come on the rise.
No, I don't think I have any more comments to add. Just that in the last slide you mentioned about data acquisition, that is also a very important part, because I feel that a lot of presenters nowadays are not people who are doing fellowship, or at least the quality of presentations that come up from current fellows is still not quite up there, because I don't think fellows themselves are prioritizing research or studies during their fellowship. So,
that's a very good point. Actually, I think it's probably in our wish list. It cannot be can be done. It should be must be done. I think that's a very, very important point. And sometimes it's disappointing to see the caliber. Yes, thank you. That's a very valid.
Thank you, Dr. Kim. Santosh, I believe, is caught up somewhere. If he will join us, we will take a stop. Otherwise, we will add them to the general discussion we'll have in the end. So, in the meantime, I'll ask Dr. Marian Pauli to present her talk on bridging the gap, interdisciplinary exposure and training. She's the head of Oculoplasty, Orbit, and Ocular Oncology in the Giridhar Eye Institute here in Kerala. So, welcome.
Thank AIOC for giving me this opportunity, and I'm looking forward to teaching this university. So my task is to bridge the gap between interdisciplinary exposure and training. So we know fellowship in oculoplasty prefers a trained to be safe, independent practitioner in the specialty, and we all know oculoplasty is like it comprises of eyelid, oncology, orbit, aesthetics, and lacrimal. But it's not ocular alone anymore. We have got lots of responsibilities, like apart from saving the globe vision, we have a responsibility to save the life, and as well as psychosocial rehabilitation also. So now, what can be done for this? So it needs interdisciplinary exposure and training. How? Why? So this, I hope I will be able to answer these questions. So this is a 64-year-old female, active thyroiditis with compressive oculometry with fungal corneal ulcer, right eye PL, left eye 2 meters. See the amount of specialists who has handled this patient: oculoplasty, blepharitis, endocrinology, systemic control, ENT surgeon, orbital and optic canal decompression, rheumatologist for immunosuppression, radiation oncologist for EVRP because of the recurrence of the disease. She developed steroid-induced psychosis managed by psychiatrist, and finally she underwent cataract surgery with an AIOS surgeon, and final outcome was vision 6, 6 and 6. Now, this is not always. On the other side of the coin, this is the same disease, more or less, right eye, again active thyroid disease, 64-year-old driver, right eye no PL, left eye PL plus present. He was denied decompression because of the high risk anesthesia. Even though he underwent radiation, vision has improved to 2 meters, but unfortunately he committed suicide. So there comes the role of psychosocial rehabilitation also by the oculoplastic surgeon. So, in the diagnosis of various systemic diseases, we need to work together. This is a patient presented with the type 2 adenitis. Initially she presented to the ENT surgeon for deafness. Germanic membrane biopsy was non-specific. We did a lateral gland biopsy, turned out to be GPA. So, to diagnose the systemic disease, we know orbit is a Pandora's box. We need a close association with other specialists also. Again, managing complex traumas, we always work together, neurosurgeon, maxillofacial surgeon and oculoplastic surgeon with the patient-specific implants, socket reconstruction and prosthesis. Coming to the neoplasms, I need not mention orbital adnexal intraocular. It is teamwork, medical oncology, radiation oncology, head and neck surgical oncology. All these tumors are being managed by multiple specialists. So now coming to the plastic surgery. This is a 72-year-old male, entropion following oculoplasty by a plastic surgeon. Usually we get entropion by entropion. So he had an ocular cicatrization pemphigoid which was missed, and after surgery he developed lid got inverted and we corrected the entropion. So I would like to present this quote. This is a quote sent to the European group of plastic surgeons and dermatologists. Who does it is not so important. What really matters is that it is done well. And to do it well, we must take into account that oculoplasty may be primarily aesthetic surgery, but the function of the eye must be mandatory, protected, and preserved. So the functional aspect, oculoplasty is not only aesthetics alone, it has all the surgeries and all the procedures has got a functional element too. Now coming to the dermatology, we know we work in close association with dermatologists, especially in the field of aesthetics. More than that, there are some other diseases dermatological diseases which can affect the eye, which needs intervention from our oculoplastic surgeon. So this is a case of ectropion. He had pemphigus on immunosuppressant, chronic ectropion, and we did ectropion correction and we did well. Later we underwent cataract surgery also. Now, coming to the radiology and pathology, this I need not mention. It is like hand in hand, you and me today, tomorrow, forever. So these two specialities are like the right and the left hand of us. So including interventional radiology. So from all these things, we know how important interdisciplinary approach in each case. So interdisciplinary approach helps in the exchange of knowledge and it helps us to manage complex cases in a very effective manner. More than that, it reduces inadvertent medical errors and legal battle. That improves patient care and outcome. More than that, it builds leadership, teamwork, and communication skills. So, team means together everyone achieves more. So, that is really, really very, very important in the field of oculoplastics. So, this is another case, 45 years, again active thyroid eye disease, but he has chronic diabetes with renal failure awaiting transplant, deconversion was denied, seen by multiple. Here comes the plastic matching. We just did a blepharotomy under local anesthesia and he did well. So, what can we do? What can be done to develop such kind of approach in our fellows? So, I am suggesting it is for a discussion also. One is interdisciplinary meetings. This slide I have taken from BOS. So, they have invited head and neck surgeon, skull base surgeon, then all the other radiologists for the oculoplasty meeting. This is I have taken from this BOB's website. Another thing, surgical skills transfer course. So now we know Akshay working, Kasturi Madam and I master. So lots of things we can learn from other specialities by this short courses, 2 days or 3 days course. So that has to be done. Another thing that can be done is interdisciplinary clinics. So we can work with the rheumatologist, or if they are willing, they can come to our clinic at least 1 hour in a week or 2 hours in a week or 2 hours in a month. So interdisciplinary clinics that will help to improve the knowledge as well as patient outcome. This one I have taken from internet. The rheumatologist and oculoplastic surgeons community partnership in Oregon. There is one Indian oculoplastic surgeon also, Dr. Hart. Another thing that can be done is to attend other specialty meetings. For example, after 2 weeks, in a nearby venue, we are having Indian Thyroid Society meeting of their annual conference. Similarly, you can attend all radiation oncology conferences, aesthetic surgery conferences. So that also will improve our knowledge as well as our fellows' knowledge. I'm so blessed in Gather Institute. We work with a group of specialists from all the specialties, and we have developed a good teamwork. So to conclude, cooperation rather than competition is the key to success. And oculoplasty serves as it bridges the gap between the multiple specialties. So I think we have to work together to develop this interdisciplinary approach towards each oculoplasty piece. Thank you.
Thank you very much, Dr. Marian. So that was an excellent coverage of all that is important for us to remember that we are just not dealing with the eye; it's part of the body, and there are multiple other things that we need to be trained and keep our eyes open for when we are dealing with patients. So I think we have a little bit of time, and we have experts like Dr. Akshay and Dr. Kasturi who have been long involved in training residents and of course setting pace for a good oculoplasty oncology program. So we'll just take a few comments and any questions that we have. So just read first. Maybe you can sit and we can have your next.
Very good presentation. I always believe that oculoplasty is something a combination of science and art, and I also do some amount of intersegment surgery. I feel this is the only surgery which is non-reproducible. Every surgery is different, every patient is different. And when we look to the oculoplasty surgery, though we basically do around the eye, but actually we need to have a full knowledge about the face, about different muscles, because all the muscle ultimately ends in the eyes, periocular region. And if you really look to the literature, the face doesn't belong to anyone. It belongs to the oculoplasty surgeon, it belongs to the neurosurgeon, to the maxillofacial surgeon, to ENT, everyone. So what Dr. Marian has mentioned, that interdisciplinary exposure is really very important. And even now, I meet my fellows that some amount during the training, they need to go and visit a plastic surgeon. They need to go to the maxillofacial surgeon. That is so important because if there's a case of fracture that is being dealt by the maxillofacial surgeon, that is also being dealt by a oculoplasty surgeon. But the approaches are different. So you should know every approach, whether you need to go through the skin or through the inside the mouth or through the orbital approach. Likewise, I feel that every aesthetic surgery has a functional indication and every functional surgery has an aesthetic requirement. So this interdisciplinary exposure training during the residency and also during your fellowship program is very, very important because we are here to learn from each other. Because this is a part which is done by everyone by different approaches.
I think Dr. Williams' presentation was fantastic, and it just gives you an idea. If they say that spectrum of cases was seen in a 2-year period, the fellow who's been accompanying her would have such exposure to the kind of cases, the different specialties that handle it, and then that is the self-propagating prophecy. Because now there is a fellow who's trained, who is aware of how different specialties work, and that person may eventually will have be trainers of his own, and also in his clinic he will be the first one to be able to identify who needs to go to a radiologist and who doesn't need to. So I think not having exposure to interdisciplinary patient care during training eventually trickles down to your practice, because then the moment you see a patient of thyroid eye disease, that saying, if you have a hammer in your hand, everything you see looks like a nail. So if you've never dealt with interdisciplinary management of a patient, you will keep trying only your technique of medication. Like thyroid eye disease, the only thing you can give is steroid, because as someone who doesn't have exposure to multi-speciality care, that's all we do. So I think it's a wonderful idea that.
So Akshay, so this is a problem that we face in medical field in India. A fellow with Dr. Marian, with Kasturi, or with you would obviously see this wide, spectrum of cases, get an experience of understanding how to deal and when to look for support and what are our limits. And, even in the best of cases, we are all looking for support from interdisciplinary experts. But we know a lot of places, these fellowships are running where the kind of exposure and the kind of skill that exists is borderline. So what would be your essential kind of, I would say, rules or guidelines when we are talking about fellowships in oculoplasty, tumors, oncology, as to these. So this is the duration of the fellowship, of which this much time must be spent either directly or in collaboration with something. So that would be something we all should, kind of create and put as best practice.
Looking back, the DN Implement of the National Board curriculum very nicely outlines things. Diagnostic skills, clinical skills, and surgical skills into 3 columns. Must have, should have, and good to have. So I think if you are able to do this, recreate a similar pattern in our own departments, where it is must have that they should go say post registration, examination, blah blah blah. Good to have is to have exposure to a radiation oncologist, or at least planning of how radiation is done, etc. So that at the end of, say, when you have periodical assessments, at 6 months, you can assess and see how much of the good to have they achieved, and then they can focus a little bit more on that. And I think acceptance and acknowledgement is the first step. That those 4 domains of knowledge. You know what you know what you don't know, and you don't know what you don't know. So I think it's important to know what you don't know, so that you can assign that for someone else to teach the training, and that comes in.
Answering to Dr. Rohit's question, that how long the fellowship program should be in oculoplasty. That was your main question, right? So I have really researched into it. So when we first started oculoplasty fellowship, it's way back 10 years back, we had a 2 years program. Then visiting many national and international programs, they said that why you're wasting the time of a well-trained ophthalmologist and making it such a long program. Then we slashed it to 18 months. And then again we slashed it to 1 year. We don't know, it should be like 1 year is sufficient. They're so well-trained residents, so 1 year they should be able to complete their training. But ultimately doing multiple formulation combination in the last 8 years, I have realized that 2 years fellowship is most important for plasty, because what at the initiation I mentioned, it is a non-reproducible surgery, and sometimes one case like the cruisons, I think very recently I presented cruison, you get hardly 1 in a year. And sometimes I am also associated with some charity work, mission smile. So those type of cases defect, you get hardly 2 or 3 in a year. So it should be an 18 months full fellowship program, and the last 6 months they should be given independent OR and a OPD, and at least 1 OR and 1 OPD, and 4 days they can be with their mentor. So this really builds up the confidence. And what I have seen in the last 2 years, after we have adopted this, all the fellows that are being trained out from our center, they're very confident in whatever surgery they are doing. So at least they get a 6 months period where we can independently do the surgery, whether it's a fracture, it's a thyroid operation. Like normal lid surgery, anyone can do, but those complicated, like those bad cases of thyroid and the lids and the maxilla surgery, all those things. So to make it a very holistic program and a full trained program, I think it should be a minimum of 2 years.
Great. Dr. Mukesh, any comments on training fellows in oculoplasty?
Yeah, actually I joined just now, but I fully agree with Dr. Kasturi that at least 2-year fellowship is required for full grooming up of a fellow in any specialty for that matter. Because he or she needs to read also about that specialty in detail, then follow the mentor, see the patients, do things himself. So it requires 2 years. So that's my take.
And about
2 years allows you enough time to see your own followers.
yeah. So and what about how to arrange for exposure with, say, a general plastic surgeon, a facial-maxillary surgeon, which are of course exposures that are, I think, very, very necessary when they are dealing with things. So how would you consider arranging? Like I said, in a big institution, yes, it's not so difficult, but in like your case is outstanding of a plastic surgeon, but now in practicing in a single eye center. So how would you get your fellows to get that widened exposure?
That's an area of real concern actually. So all fellows they need some amount of anterior segment expertise also, at least in North. Like they want with their Oculoplasty fellowship or for that matter any other fellowship, they want to do some cataract also. They do not want to be away from cataract for 2 years, one. And then the other specialty trainings. For other specialty trainings, we can do licensing with the like-minded person who are having their own setup. Obviously, a fellow needs to go there. They cannot come and teach fellow anything at our center. So one day in a week, a fellow can go there. But this mentor has to arrange with the like-minded person. And similarly, for cataract surgery, also some collaboration is mandated. So that's the real problem for any private center doing surgeries and trying to have a fellowship program.
Yeah, actually, the challenge is this: a lot of specialty is now residing or expertise is residing in experts who are having their own clinics or own places. I mean, no more they are the kind of place where you're looking at a very large multi-speciality hospital where extensive exposure is being provided. So that is why the challenge in our kind of specialties where we want them to have exposure to other experts, but obviously that's not a key part of the curriculum. So any other comments before last couple of minutes before we close this? Akshay, any tips on how to run a good teaching program? Yes, please.
So what are they doing for the 3 years of MS?
So that's a question I think a lot of us are
I'd like to
kind
add
of
one
trying
more
to
thing.
search out.
There's a what I have concluded over these few months, I should say. There's a thought process going on in the resident's mind. Residency is for earning. Fellowship is for learning.
So I think it's, like I said, very unfortunate. We're also kind of really realizing how our residents should be, and that's what I was mentioning, that unfortunately many of these educational institutions lack the expertise and the exposure to multi-speciality, which should be actually, why should we need so many fellowships and training programs? I mean, in our time, a resident was trained to even go do retinal surgeries in their, medium-sized towns, and many of my batchmates never stayed back in RPC to continue doing any senior residency or any further training, and today they are like leading experts in plasty and retina in their own particular places because they just continue to do that. So, and had good exposure to specialty as a resident. So, it's unfortunate that it's getting down and our residency programs are deteriorating, and therefore we're talking more and more of getting our fellows to learn specialty as well as continue to train them and upgrade them in general cataract surgery.
I feel that no.
Faculty where we have the MS and
Absolutely, I think it is. I mean, you can, as Dr. Kim had mentioned, you reap what you sow. So if I don't teach them well, how can I expect them, or if I don't perform my specialty or transfer my knowledge to them, how will they know? So it is bent upon us. I think it is surely our responsibility to train our next generation. It is absolute. If I don't train the next, how do I expect my fellow to look after my OPD for me? So it's, I mean, other than of course a moral responsibility, it is an actual benefit for me. Like I'm here today, and my OPD is tomorrow. Somebody has to see that. If my senior resident or fellow is not adequately trained, who is going to look after that? I'm going to get phones on my cell all the time. Nowadays, there are not those days when you just forget it and they keep calling and trying and searching in the hospital. Now everybody has cell phone numbers. So,
I feel the residency is basically we really need to treat them in comprehensive ophthalmology so that they come out as a safe surgeon, they come out as a safe doctor. That is very important. And fellowship is something like super specialty, like a PhD program. We don't have PhD. Like you cannot expect a residency because we have unit posting 1, 2, 3, 4. In the 3 months unit posting to learn how to do a back forwarded fracture, how to do a decompression. But yes, there must be a safe surgeon. And today in the morning we are discussing that in the court of law, if there's any complication coming, if it is whatever is in the curriculum, they should know. Like supposing someone had given a Avastin injection and came out with some complication, then there's a case been going on. and he says, no, I have done a fellowship. No, that will not, give any, credit in the court of law. What they say, that isn't in a residency program. Have you learned it? Okay, you are a MS, you are supposed to know you have done the right thing. But we are talking about fellowship program. That is something super specialty. So for that, it is not possible for the residents within 3 years to know everything. But what I believe, we need to train the residents in such a way that they are very good comprehensive doctors and they can do good cataract surgery. They should be able to do the basic oculoplasty, endopion, ectopiontosis. They should be able to do a good pterygium surgery, the lasers, everything. But sir, those complicated cases, I don't think residents will be able to pick up.
Absolutely.
And 6 months to go in the thesis.
They should learn to treat the vast majority of 80% patients and recognize those 20% patients which they can't handle and need to be referred to the appropriate person. So that's, I think, the crux of any residency training.
Can I add one more
Yeah,
point?
please. I think
Actually,
that.
looking back, these wrong seats are sown during MBBS. The day they join MBBS, they are seeing just like dots at PG. That's the biggest problem that we are having in medical college. It's having MBBS students as well as PG, and if they are not interested in other specialties, build the MBBS.
I think
When
even
they come
bigger
to-
problem is pre-PG or need. Because of that, now MBBS practical training is zero. Zero. So saying this,
MBBS is an unemployable graduate. Right?
No,
But it was,
environment. But there is still practical training. Previously, resident used to do independent suturing, hernia repair, hydroceal repair. They were things practically useful. Nowadays, it is things out of the field. Everybody is reading.
It's unfortunate that it's come to that, but yes, we should do our bit in whatever we can, both from a residency perspective and of course from fellowship. So I think we'll close the session here. Thank you very
one
much.
more half a minute.
Okay, sure.
I was there as an examiner in a medical college for university. I was checking the copies. I started having tremors because these people are going to handle me. Unfortunately, I don't want that. If
I understand.
I get
That's
admitted,
what
what will they do?
it is incumbent upon us to raise the level of teaching and training for the next generation, so that and that's what these discussions were for. Hopefully, we'll be able to take back and implement some. And again, thank you very much. Thank you everybody for being here. It was an absolute pleasure.
I said,
And I think the crowd is here. I'm not sure so much for the whispers in oculoplasty and more for the quiz. So